Welcome to Connecting the Dots. My name is Mark Lardner. This is our first episode of the new year as we continue to explore innovative approaches for translating assessment data into meaningful metrics. If you are new to the TCOM channel, as always, please subscribe. We're adding new content to the channel every week. So set aside some time, watch some videos, leave some comments, and explore the channel. Like all our conversations, we're hoping today's conversation can be collaborative. So if you're watching this live, please use the chat feature to say hello and join the conversation. My guest today is a clinical psychologist for children, youth, and their families, and the senior child and youth mental health clinician scientist at the Knowledge Institute for Child and Youth Mental Health and Addiction. We're going to talk about improving clinical pathways to care using a TCOM tool that you may be unfamiliar with, the HEADS-ED. And so he comes to us today from the beautiful capital city of Ottawa. Please welcome Dr. Mario Cappelli.
Hi, Mark.
Hey, Dr. Cappelli, so good to see you.
Hey, glad to be here. And thanks to you, the folks at Connecting the Dots and the folks at TCOM. Really excited to share some of our work.
All right, great. So we're excited to hear about it. So maybe let's just start there. We'll start with the HEADS-ED, how it was developed and maybe how it's used.
So a really interesting history of how this all came about. And it really started with our own research looking at young people as they came to our emergency departments and the struggle that physicians were having in terms of identifying what to do and how to assess their mental health needs and where to best determine services that would meet those sorts of needs. And so if you looked at the literature out there, they talked about not having any tools and not knowing what approach to use. And so it started way back in it was 2008, 2007. So the idea was, can we develop a tool that physicians and emergentologists or pediatric emergentologists, other emergentologists can use as part of their super fast, brief meeting with the families and the youth to say, okay, here's what we need to do next. And that's really the history of it.
So, and again, I think a lot of times our focus in building out systems is saying, well, how do we get all the support service interventions we need? And sometimes a step that's missed in between is, well, then depending on which doors people walk through, are they able to get to these actual support services or interventions? And so talk to me about how the HEADS-ED then, what role it plays in maybe making those connections.
Sure. So I think, at some point we must evolve. I don't know anyone who's never been to an emergency department or, and actually I was just there the other night with my daughter, who suffered a fall. So we kind of know how chaotic emergency departments are. So the idea was, here's an entry point or a gatekeeping point for services. And it's so important for a lot of families when they first enter these gate points that they get, that positive experience that the person seeing them actually is skilled and is able to help, meet some of those needs. But physicians in the emergency department, and our goal was, again, to support physicians. I was working in a hospital. If you think about what their needs are, because they come with a certain set of needs, and their needs are, I need to get these patients through this system as quickly as I can. So if we have to develop a tool, it would have to have certain kinds of parameters. They have to be really brief. It requires little, no training, because if you have to train physicians, they're not going to do it because they're too busy. It's got to be super simple to administer, to score. They want data to support what they do, so they want to know that the data that the tool actually does what it's supposed to do. But at the end of the day, like all of us, they need to know that whatever they're doing is actually going to help them in their clinical decision making to deliver care. But from our perspective, that's great. But we also wanted a tool then, because we knew that what happens after they go to the emergency department, the child's going to go somewhere. So you wanted a tool that then would help the physician in terms of them deciding, is this a child that needs services within our emergency, within our crisis care, or does the child have to be admitted, or does the child have to be discharged to one of our community resources? So wouldn't it be great to have a tool that physicians can then communicate with our community providers to say, here's what we're concerned about, and here's why we think this would be the best place, to get care.
Right.
And then the last piece would be the idea that regardless of which emergency department you went to, that the pathway to care would be similar, whether it's here in Ottawa or Washington or Kentucky or wherever you might be.
Right. All right. So I think most people who are listening who have any familiarity with TCOM tools, you got their attention right away by saying easy to use, minimal training, brief. So let's get into it. I know you we have some slides that go along with this to really get a look at the HEDS ED and maybe kind of just put some of what you just described to some content. So here's one just about its conception.
So really there were two sources of information that we used. So the first one to help develop the tool was we said, well, what are physicians, what's their understanding of mental health needs currently? And there's a mnemonic that's taught in medical school. It's called the HEDS mnemonic, and it's gone through different versions of it. If you Google HEDS today, you might have 4 S's or 5 S's and 2 D's. But it's a way that they've organized their thinking when they are doing a psychosocial interview. So we wanted to use that mnemonic because we knew that they would already be familiar with that mnemonic. And then we were really fortunate at CHEO. We had Dr. Lyons, and John was working at our center as the endowed chair of child and youth mental health. And we were all familiar with CANS and TCOM. And we said, well, is there a way of taking the concepts of the CANS, which is understanding needs and strengths, and blending it with the HEDS mnemonic and making it really, really concise and short and brief? And that's where it really started. And so if we take a look at the tool itself, the mnemonic is on the left, and then the levels of need are at the top. And essentially that's the tool. And in our original studies, all we did was staple the tool to the front of the medical chart of the physician seeing the youth, and we'd say, take a look at this, and this might help you guide your assessment of the child and what you need to do next. And that was the extent of it. There is this is the original tool that was developed for kids over the age of 6. And then we also developed more recently a tool for the under age 6. And you'll notice 2 things. One, the mnemonic stays the same, right, but the domain has changed a bit. So whereas in the over 6, we're interested, for example, in drugs and alcohol, for younger kids, we're actually more interested in developmental needs. So that's where the D changes. Again, the idea is that this tool could be used now not just in emergency care, but for other physicians who also act as gateway keepers. So, for example, pediatricians who are family physicians, who often will be the first ones to identify or have to think about identifying what concerns are, or what the mental health or developmental needs are for the little ones. So essentially, that's where the whole idea of the tool came from, and the concept of the tool. And in some ways, we were really, we're really, really fortunate because John was working with us and he was at our center. So it was just a coming together, perfect timing, perfect place. And we took the best of, I think, two different domains and blended it together. And now it's being pretty widely used in Canada and in other places. And so super, super thrilled to have the tool take off as much as it has.
And I love this too, because what it illustrates is the very flexible nature of TCOM. As long as you're hitting some of the key points in which you raised, which is that one, do we have a structure in which the clinician or the assessor, whoever is using it, can communicate the needs of the family in an action framework? And so you don't have the 4-point scale, but you have a 3-point scale, and it's, we don't have to do anything. We have to do something, or we have to do something right away. And this then supports decision making, which is the other key piece, right? And perhaps the third, and that's maybe something we'll talk about later, is that how do we use these things to understand how people change or how people get what they need? And so maybe you can talk to us a little bit about how it's implemented, kind of where you are in the hospitals, right, or other, the general provider offices in Canada.
I should let you know, Mark, it's just interesting you mentioned like how the like the CANS, and it's based on 4 levels of needs, right? The physicians, when we were proposing it, we actually started with 4 levels of need.
Oh, is that right?
Yeah, okay. We did. And they said, there's no way that we'll ever do a 4-point, 4 levels. They wanted just 2 levels of need. Basically, we do something, we do nothing, right? And we said, well, I think that's a little bit too brief, right? We need to have at least something more in the middle where, we don't need to act necessarily right away, but we need to kind of monitor, right? So I think, it kind of, you could just see what their needs and what our needs were, how it kind of, there was a bit of tension.
I like the idea that the 4-point scale is a bridge too far for the doctors saying, no, it's too much. You can't do it.
And again, I think if you think about, where it came from, the idea that in an emergency department, most physicians, if you have 5 minutes with them, that's a long period of time, right? And when they're dealing with mental health, concerns, they get all distressed because they know their 5-minute time limit is going to be used up pretty quickly, and they have a roster of other patients waiting to be seen. So the need to make it quick. That's why they wanted the 2, but they bought the 3, which is great. And so what happened is that as we started doing some work and people started hearing about the HEDZD, at least particularly in Canada, we were approached by the IWK hospital that provides mental health services for the province of Nova Scotia. And they had asked us, do you think we can use this tool as part of our intake, at least in that very initial kind of phase where we're, first meeting with the family and trying to determine what next steps to do? Can it help us? Can it help guide, our intake process? And we said, well, don't know. Why don't we, implement and see what happens? And so they were the first ones to implement it within this kind of centralized or this initial point of intake. And we found some real promising data. And so it started taking off there as well. And so it's integrated now in a bunch of different pathways. So one closer to home is our coordinated point of access, which is called One Call, One Click. And families and youth can either call directly, call one line, they'll talk to one of our intake workers, or they can go online and schedule an appointment and we'll meet with them. And part of that intake process includes where the intake worker will use the HEDZD to gather a little bit of the information to help determine the level of need, and also help determine what services that they need to identify or identify the type of service that they would need in order to meet those needs. It's been implemented in a number of emergency pathways. It's actually part of a clinical pathway for the province of Ontario. It's being used in a number of different emergency departments throughout Canada. I know that there's been some uptake in other jurisdictions, and it's also been recommended in the U.S. as part of their pathways for accessing mental health services in the emerge. The one thing that we have done when we developed the tool, we also did what's called the Creative Commons copyright. And we wanted the tool to be easily accessible, and I can't really tell you who fully uses the tool. And I can tell you who the folks that we know use the tool, but I know that there's lots and lots of other folks that don't. More recently, we've also taken it into primary care, because family physicians, if you take a look at if you ask kids where they first try to access mental health services, it's often with their primary care physicians. And in fact, about 60% of the times, that is the first entry point to care. So the idea that, your primary care provider having a tool that would help guide their decision-making, their understanding, how important that could be as well. So we've done some work looking at primary care pathways as part of that integrated care, at least in Ontario. So a couple different places. And we've looked at some of the data that from collecting, both utilization data as well as HEDZD data to see how well the needs align to services.
So that's what I'm curious if you can talk about that next, because certainly it seems that these 3 pathways, the ones that are up on the screen now, would be the ones that would make the most sense, right? You have youth or families coming in through an emergency department, certainly a chaotic environment to describe in China. Can we quickly do something that helps put them in the right position? And in fact, I think when you and I spoke earlier, you quoted me some stat about the level for youth or the families who are visiting emergency department, what percentage of these actually are low-level need, and are not in the right place. But oftentimes we're getting just kind of lost in the sauce where, they're in the wrong spot, but not able to get to the place they need. And that the heads ED has some role in kind of, solving that problem. And then in addition, in the pediatric care office, where again, emergency rooms, you have short turnarounds, but in your PCP office too, they don't have a lot of time to spend with you. So just the impact that's had, kind of any of your research and your findings on how it's been used.
Great. So one of the things that we did was we actually took a look at things like the overall score on the heads ED, right? And the idea that, okay, if you just simply added the zeros, the ones and two, what does that total score look like? Right. And how does that total score align with level of need if we're looking at a step care type of model where, the lower level of needs are ones that could either be, met with, simple, like a walk-in clinic or general information, and you work your way up to more intensive or complex levels of needs. So we looked at the overall score of the heads ED. But when we did that, we were also really mindful that, unlike psychometric measures, which live and die by data, our instructions are pretty clear that it can't just be the score. It has to be understanding what the level of need is, even within each of those domains, right? So in other words, if the child is, if there's significant challenges, for example, in one of those domains, it doesn't matter what the overall score is. That domain in and of itself is incredibly important in communicating. Right. But when we took a look at the overall score, and this is based on the kids coming through our one call, one click point of contact. And the data here is roughly, I think it's like 4,500 kids that came through. But the first thing you'll notice is that there's a clear line as the level of scores on the heads ED increase from 2 to the complex need of 9. It also corresponds with what types of services the child would need. So the kids who present with higher scores on the heads ED also present with more, would respond better to services that respond to more severe and complex needs. Yeah. So there's a real nice line. And why that's really important is that if you just take the referral and there's no way of triaging or screening that referral, then they all stay in the same wait time. Right. And that's why this is important, because with a easy, triaging and easy screenings using the heads ED, you're almost looking at 30% of kids that present with either general population or low level of needs that can be quickly directed to services and don't necessarily need to wait, right? And so you're taking them off a wait list that potentially could be serving kids with more that may be dedicated to moderate or higher needs, and they're sitting there waiting as well. And then you increase the potential risks because they are waiting for services when you could have intervened earlier. Right. Similarly, you don't want to have kids who present with moderate to more severe complex needs wait along with the kids who present with low level of needs, when again you can quickly screen and get start moving that pathway forward, right? So incredibly powerful finding. The other interesting thing too is that if you take a look at so this wasn't just for the older kids, even with the younger kids, we found the same thing. So if you take a look at the scores on the under 6 version of the heads ED, again, that there's a direct line, scores go up, level of needs go up, and vice versa, right? So don't have kids waiting, for services when they can be getting those services quickly, and ensure that the kids who require more intensive services get those services more rapidly as well.
Right. So in this use of this, then, have you seen the system's ability to kind of optimize their, not only where kids are being pointed to, but just, the wait times for accessing services, and then potentially, does it have an impact on the amount, any use of this to try to right size how much we need of different types of services across our system?
So one of the studies we did was we looked at implementing the heads ED in a primary care pathway. And this looks really complex, but it's actually not that complex. It's really pretty simple. like you have at the far left, the child and family present to the physician's office. The physician does the head CD tool as part of their normal, meeting with the family. And if they score above a certain cutoff, you see them being directed to the emergency department, particularly they score, we usually talk about a score of 8 or a suicidality of 2, or, you send them there. And then if they score below that, then they're referred to our community-based services or more of an outpatient-based service. And then the nice thing is then because the folks at the community level also understand the head CD and use the head CD, when they get the head CD from the family physician, it makes clinical sense to them. And then they can then respond back to the family physician or the point of intake saying, hey, thank you, got your referral. We recognize the level of need. Here's what we're going to provide. So it looks really complicated, but it's actually pretty simple. There's only like 3 steps. And so one of the things that we did was we looked at a couple kind of outcomes. One was there uptake in the tool by physicians?
Okay.
And so when we looked at it, we had like 90% plus intake in the use of the tool. So physicians felt perfectly comfortable using it, right? And happy to use it. The other really interesting thing, Mark, is that we asked families, and it was about 4 to 6 weeks later, what did you think of your wait time?
Yeah.
Right? Because we all know, I'm not sure what it's like in the US, maybe it's different there. In Canada, I could tell you that wait times for any healthcare is not great. And for mental health care, it's even worse. But we asked families, what did you think of your wait time? How satisfied were you with your wait time? And surprisingly, we thought for sure we were going to get it's awful, it's terrible. That's kind of what you intuitively would think would be their feedback. Instead, what we got was that they were satisfied with their wait time. And when we asked why, it's because they felt those that needed to be seen were seen, and those that could wait felt that they were okay waiting, understanding that they were heard and understanding that there is a wait time, but they also understand that it was okay to wait, right?
Yeah.
They were more accepting of it, right? And again, it's different than when you just go in and just fire off a referral and you go into this black box and don't know what they're basing it on. When am I going to be seen? What's the follow-up, right? So a couple simple things really, affected, people's perception of their wait time. And also, I think at the end of the day, assured them that maybe we are kind of mindful of what's going on and we're not just ignoring their needs.
Yeah, I think, in reading through some of the literature that your team has put out too, it struck me that part of this perhaps it's the understanding, like in using any of the TCOM tools, when you have part of the strategy is clear communication, and that people have expectations of what the wait time is and why there's that wait time. So it's less maybe about, like all of us inside, we live in a very immediate culture. We want everything right now or as soon as we can get our hands on it. But knowing that, hey, I went through a process where they determined exactly what I need. And so now I'm reassured that when my name is called, at least that's the thing that I'm going to need. It's not going to be another process of like, is this the right thing or not the right thing for me? So, but that is a fascinating finding that, even with some wait times, people feel like that's okay as long as they're going to get what they actually need.
We have the tool is in Ontario is currently being implemented in a province-wide virtual walk-in clinic. Okay. So, and the clinician does the head CD. It's a one session, assessment and treatment. Just one quick session, right? And you do the head CD. And part of it too is that they use the tool then, to say, here's why it's only going to be one session, or here's where you can get a couple more sessions, or here's why we think we're gonna stay on the line with you, and we're gonna connect with the agencies in your community to help link you to services, right? So the idea that, again, it's very interactive and interactive in the way of communicating, to the patient or the client what it is. On our pathway stuff, it's again the idea that it's the client knows, the provider knows, the agency knows, and the hospitals know the same information.
Mm.
It's not like he scored or she scored 10 on anxiety and something on something else, right? It's like, what does that mean, right? We don't really know. But if we say, there's situation at home is really chaotic and we're really worried and needs immediate care, kind of makes clinical sense. It fits that, that model beautifully.
Yeah, it sounds like it. So then what's next for your work with the Heads ED or this kind of the research you're doing?
When we started just doing some of the pathway work, we were telling physicians and these agencies, listen, we can't be using paper-based all the time. We got to go, to more electronic-based e-referrals, electronic-based. And we were said, not now, not now, not now. And then the pandemic came, and now is the time. And so we're actually doing a lot of work, or increasingly more work, on how to implement the Heads ED tool within the e-referral platform that physicians use in the province of Ontario, and connecting that e-referral to the agency. So now they would automatically do the tool as part of their e-referral. So again, very low-hanging fruit, easy for them to do. They use it all the time anyway. If you went in for challenges with your knee and they had to send you to a specialist, they use those tools to tell them what state your knee is in, right? And this is the same thing. So we're always trying to use platforms and that they're familiar with, but we want to take advantage of what we know makes really good sense from a mental health perspective as well. And so the idea that we move towards those e-referrals, models of communicating is, I think, really, really important.
Yeah. I mean, that's the thing. For any communication tool, the only communication is digital communication by and large, right? Even now, you and I are having a digital communication through Zoom or through this platform we're on. So that's exciting. I think, too, when I was doing some of the research, I came across a website that had built it in. I think it was like a demo of how the Heads ED worked, but it really was a seamless, as I walked through it, completion of the tool that only, honestly, when I was not interviewing anyone, but it was minutes to kind of work your way through it.
Yeah. So we do have it's www.headsed.com. If you go there, it has, and again, you could just see, John's, fingerprints all over, because we worked on vignettes together. We worked on how to do training together. So if you go to the website and you'll see like, oh, I've seen this before, kind of, right? So for us, it's going to be really nothing new. But again, the idea that instead of it being a 45-minute or an hour, it's tiny short, right?
Yeah, love that. All right, well, that kind of brings us to our time today. I gotta say thank you so much. It's been a pleasure learning more about the Heads ED.
Thanks for having me, for sure.
Yeah, great. And we'll have to touch base, hopefully maybe at a conference some point in the future. We have not been to TCOM conference in Canada. We got to make that happen.
I'll give you some suggestions. Not Ottawa. I want to go somewhere too.
Maybe not Ottawa. Yeah, let's go somewhere nice. All right. Good to see you, Doctor.
Take care.
All right. Well, thank you so much. I have to say, I think I say this a lot, but one of the best parts about working in this space and being part of the TCOM community is the people. People in the TCOM community are the best people. Certainly, Dr. Cappelli is one of the best of the best. What a treat to have him share his work with us. And so that kind of wraps us for our episode. But before we leave, a couple quick announcements about things coming down the pike for us. So these QR codes that you're going to see on the bottom of the screen, please visit our blog, tcomconversations.org. There you'll see that there's another What If seminar that we have. It's on March 26th. It's a conversation about advancing global population health with AJ Gupta. Also on the TCOM Conversations blog is a call for proposals for the next TCOM conference. Sadly, it's not for Dr. Cappelli, not going to be in Canada, but we are going to be in San Francisco in October. And I think proposals are due towards the end of March. So please enter your submissions. Every year we have some of the best conference presentations. So I look forward to those again this year. Again, follow us on Instagram. That's a good place to stay in touch with everything we have going on. On Instagram too, you'll notice one of the most recent posts is about our podcast Tales from the Collaborative. The most recent episode is with Dr. Robin Orlando. And if you have a spare 17 minutes, it is incredibly enjoyable listen to Dr. Orlando chat with Tim Fall about her work in TCOM and her thoughts and ideas about the TCOM work. All right. So thank you again. Thanks for tuning in. I look forward to seeing you on the next episode of Connecting the Dots. Have a great day.